Good evening and welcome to all the delegates, the faculties, the dignitaries, and all the panelists for this session 2026, the MR Safety Call for Action series. We are continuing the Call for Action series that we started in 2025. We had 4 webinars last year, and this is the 5th one and the first one in this year. And this year, for the Call for Action series, we are having a country focus apart from bringing in the call for action points that have been published in the Japanese Journal of Radiology in January 2025. This year, we start with the India focus session. And I am extremely happy to have the blessings and guidance of the President of AOCR, Dr. Chamari Chuapechaparason, who is here with us, will give us the opening remarks. Over to you, President.
Thank you, Dr. Rijo. Good evening, colleagues and friends. On behalf of the Asian Oceanian Society of Radiology, it is my great pleasure to welcome you to the AsiaSafe AOSR MR Safety Webinar 2026, our Indian focus session. Thank you for joining us as we continue our shared mission to advance MR safety across the region. In 2025, we successfully completed 4 impactful MR safety call for action sessions, each strengthening awareness, collaboration, and practical knowledge. Building on that strong momentum, we are committed to carrying this work forward in 2026 with even greater focus and engagement. Today's speakers and panelists bring exceptional expertise, and your presence enforces our collective dedication to ensure safer MR practices for every patient. Thank you for being here, and I look forward to a productive and inspiring session together. Thank you.
Thank you, President Dr. Chamari, for that inspiring words, and we are always grateful to you for the support that you have provided for the MR Safety webinar series. Thank you, ma'am. Now we will move on to the opening remarks and message from the Chair of AsiaSafe, Emeritus Professor Dr. Kwan Hoong Ng. Sarida, please play the video.
Good day, dear colleagues. My name is Professor Ng, the Chair of the AsiaSafe of AOSR. I'd like to welcome you to join us in this series of MRI safety, and it is based on the document MRI Safety Call for Action that AOSR AsiaSafe published early 2025. So we continue with this series, and we will begin this portion of inviting different countries in Asia Oceania to speak about their experiences, the challenges, and various issues in implementing MR safety. And this will continue throughout the rest of this year. So we look forward to your participation and your feedback to make sure that MRI will be safe for patients, for the operators, and everybody. Thank you.
Thank you. That was Professor Kwan Hoong Ng, the Chair of AsiaSafe, who has been very supportive. We have started his activities from 2021. Professor Ng and all the presidents of AOCR right from 2021, Dr. Evelyn Ho and Dr. Noriyuki Tamiyama and Dr. Chamari, all have been very supportive of this particular movement. And this has taken a great shape now in the Asia-Oceanian region. Now every country is noticing the MR safety webinar initiatives, and the MR safety sensitization campaign is going on in every country of this region. So the focus I've already mentioned for this year is country focus has also been added. We want the national leaderships of the radiological societies actively get involved in the MR safety campaign. And for this session, we have included the India focus session. And to give us the opening remarks, we have the dynamic president of Indian Radiological and Imaging Association, who has spearheaded several movements in India and has taken charge recently at the National Conference of Indian Radiological and Imaging Association at Hyderabad, India. I would like to invite the president of Indian Radiological and Imaging Association, Dr. Sandeep Kautale, to give us the opening remarks before we go into the academic session. Over to you, Dr. Sandeep.
Thank you, Dr. Rijo. My distinguished colleagues and friends from the AOSR. Good evening, Namaste. On behalf of IRIA, I welcome all of you for this webinar. I would like to begin by thanking Dr. Chamri, President of AOSR, for a visionary opening remark. A special word of appreciation must go to Dr. Rijo Matthew. Dr. Rijo, your tireless work as a coordinator and your passion for MR safety have been the driving force behind this webinar. I also want to acknowledge our esteemed speakers today, Dr. Murali Krishna, Dr. Sheeba Kumari, and Dr. Amel Antony. In India, we are witnessing a massive surge in the installation of high-field MR systems. However, technology without a safety
I think there was a connection issue. Yeah.
We must support the roadmap that Dr. Murali Krishna will outline. And most importantly, we must aim for zero tolerance in projectiles, RF burns, and hearing loss. The three major accidents that they are preventable. I am confident that the panel discussion moderated by Dr. Rijo will provide us with actionable steps to take back home. The magnet is always on. And
Thank you, Dr. Sandeep Kautale, the president of Indian Radiological and Imaging Association. He has inspired us to, and also already committed to move in the direction of MR safety and activities, and which in the first academic session, Dr. Murali Krishna will outline the roadmap for India for MR safety initiatives. Before I go into the academic session, I've got a few instructions that we would request all the delegates who have joined in to ask your questions in the chat box and enter your questions. You have to enter your name in the chat box that's on the right side of your screen. And then you can ask your questions, which will be taken up in the end of all the sessions and will be answered by the speakers and the panelists. Your active participation is very much essential for the success of all webinars. With that message, we will go into the first academic session. Let me introduce the first speaker, the President-elect of Indian Radiological and Imaging Association, Dr. Murali Krishna L., who will talk to us on the MR safety initiatives, the roadmap for India. And Dr. Murali Krishna will take charge as the president next year, and I'm sure his initiatives will continue as a roadmap for India for the next few years to come. With that introduction, the youngest president of Indian Radiological and Imaging Association, President-elect Dr. Murali Krishna, I welcome you to give and deliver your lecture on this particular topic, MR safety initiatives, the roadmap for India.
Thank you, Dr. Rijo. First of all, my sincere gratitude to the AOSR and the entire MR safety team for starting this initiative, which is country specific. And I'm sure we are going to see the perspectives of all the different countries of Asia Oceanic region and the steps that we are going to take towards this very, very important topic on MR safety. So I'm going to talk about what we plan to do in India, what are the things that have been done, what is the current situation in India, and how we can take this forward. The MR market in India is one of the fastest growing in the world, if you would not know. We have added about from 3,000 units in 2019, we have gone to about 5,000 in the past 5-6 years. We are adding about 350 to 400 MRs, new MRs every year in India, and that is the highest in this region. And the market share from 278 million in 2025, and we're expecting to reach it to 400 million at a growth rate of about 6 to 8% CAGR. So MR safety, and these accidents are something that are happening at multiple years, at multiple places. The most sensational one was when we lost this young hospital assistant in 2018 when he rushed with an oxygen cylinder for the patient, and he got caught in between, and we lost his life. And similar, we have seen multiple such incidents in India, and and we never realize it until it comes and hits us. So this is something that happened to our own MR not very long ago. So this one was again a patient who was sick, and the bystander wanted to stand along with him. Rather than stand, he wanted to sit along with him. So he just pulled the chair which was outside, but unfortunately it was a metallic chair. It flew in, and thankfully the table could move, and because the table could move, we could get the patient out without quenching, and only the chair that got stuck here, as you can see, was to be removed. And you have to understand the power of these MRs, and if you can see here, finally we all got together, we got the servicemen in, we tried about 7 8 ropes and tried to pull this chair out. And imagine the power of the magnet. Almost 10 of us had to pull this out to get the chair out. So that is the strength of the magnet, and that is what we are dealing with. So we have to understand the power of the magnet, and especially when now with more of the 3 Tesla MRs that we are all putting it in India, the more safety precautions that we have to take. Why MR safety matters, as I said, MR is the most powerful, but at the same time, it has a very high risk environment. Static magnetic field, gradient fields, RF energy is something that we are dealing with. And the risks can be because of projectile accidents, burns, implant hazards, and there is always a need for standardized national safety framework for MR. And that is something that we are yet to reach. The current MR safety scenario in India, there's a rapid growth of MR installations, as I said before, but there is variation in the safety practices across centers. We have nothing uniform. Each of these centers, some of them based on the accreditations, have their own limited structured training programs also, and there is an acute need for a uniform policy and audit system. Currently, we don't have a MR regulatory board in India. Unfortunately or unfortunately, now MR is being oversighted by the Atomic Energy Regulatory Board, which is actually to do more with CT and radiation, and has actually no role here. But since there is nobody else, ARB is doing that work as well. And there is a part of this hospital accreditation, like the NABH, which comes under the Quality Council of India, who gives some imaging guidelines and safety guidelines. But again, this is accreditation based, and India doesn't have a standalone statutory MR safety board, and that is what we have to achieve in the next few years. Why IRIA must lead this MR safety? Because IRIA is the National Radiology Professional Body, very ideally placed. It can decide on the standardization of MR safety practices across India. It can align with the ARB and the Ministry of Health for policies, and national certification and structured training programs is something that IRA can do, along with the other teaching that IRA has been doing. Adopt international best practices, the zoning concepts that we all hear about, especially those who have an NABH will know very well how these zonings work. MR safety, MR conditional or unsafe labeling. We have to start this practice of labeling all our implants and all our materials that we use. we have to have a dedicated MR safety officer. This MRSO is something that is always being not implemented in India yet. We only have an RSO. But somebody who's trained in MR safety, we should have proper incident reporting systems and regular drills and audits for MR safety. So the vision for India, we have to have a uniform MR safety standards nationwide, mandatory staff training, regulatory alignment and accreditation, and technology-enabled screening systems. Now, how are we going to achieve this? In the short term, because this is something that is going to happen over 3 years and cannot be done immediately, but we have to have an action plan. So in the short term, which is in the next 1 year, IRA aims to have a national MR safety task force, and we have to standardize at least the patient screening form. Each center or each hospital, if you see, has its own screening form. And this is something, if we can standardize, there will be wide-scale acceptability. Mandatory level 1 staff training, which can be done by IRA. Basic facility compliance checklist. We can create a checklist and give it to these the MR performing centers, and incident reporting portal. This becomes very important because we only hear the 2 or 3 fatal cases that that is get reported in the media, but a lot of MR incidents are happening every day in every city. Which is not getting reported. Even these small incidents that are happen, if they start reporting, then we can build a safety network, see where we went wrong, where that center went wrong, and create better awareness and better safety platform for our patients as well as for the radiographers. In the medium term, which is between the 1 to 3 years, we have a formal regulatory adoption. This is because I've given this 3 years time because it is not that very easy in India to have an MR safety officer certification program under the banner of IRIA. And we have to accreditation link the compliance. So all these compliances has to be there for accreditation. So we have to work with NABH and other accreditation agencies for the linking of these compliances. We have to maintain this national implant or device database. Multiple countries have started this. We don't have it in India. We have using multiple devices. Now we have the brain stimulators, cochlear implants, gastric stimulators. So all this have to have some patient comes back, he doesn't have any old report. He doesn't have a data of the implant that is put. But if we have a database, we just log in and check whether this is MR compatible or how safe MR safe it is, so that we can scan these patients safely. And quarterly emergency drills is something that we have to teach the radiology staff in case of any emergency. The long-term plan, legislative backing. This is something that in India, nothing works without legislative backing. But to get the legislative backing is a huge process. But I think if we start now, within 5 years, we can reach that. So that we have an officially National MR Safety Board. Annual benchmarking of reports is something that is very, very important. And the end game is the integration with the electronic health reports systems of all the hospitals. So that we have an uniform EHR, which is what the government of India is thinking. And we have to integrate the MR safety also into this national EHR that the government of India is planning. So the stakeholders, we have the government on one side, the IRA on one side, the hospitals and the vendors. So as a government, which has to do the policy and enforcement, as a professional body, IRA will do the education and the certification process. As hospitals, they have to implement these policies that the professional bodies give us and do the audits. And we need the help of vendors as well, because device documentation and training has to come from the vendor side. And I think if we have the legislation in place, all this will fall in with IRA spearheading this safety call. The key performance indicators here, we are looking at 100% staff safety training coverage, at least more than 99% complete screening and documentation of the MR patients, reduction in MR related incidents annually. We have to monitor this, and time-bound incident closure. Even small incidents, we have to report this and see how we close this at least within 30 days. So across India, how are we going to implement this? We plan to do a pilot rollout, especially in teaching institutions. And then once we do that, we can do a state-wise phased expansion. And digital compliance dashboards is something that IRA plans to introduce, and a quarterly emergency drills, as we said, so that we keep touching upon it, because once we do the training and we don't do these emergency drills, then people forget their training that happened a year ago. There are a lot of challenges. It's not going to be easy. Number one is, of course, the resource constraints. This is going to require a lot of funding. But I think if IRA has it in mind and with the government support, we can do a phased funding for this based on our goals of the years. Training gaps, not everywhere can IRA reach, but now thanks to COVID, we have the hybrid modules now that we're doing online teaching every day. This training modules can also be done for the radiographers and radiologists in a hybrid module, and then give out a certification. And also, even the assessing of these radiation safety, we can do a tele safety audits nowadays. Do an audit with the help of technology, and a person need not physically be there, but actually check these audits at. And of course, any new policy, there will always be resistance. Why should we do a separate MR safety board? Why should we have a separate training? But then IRA, through constant advocacy, I'm sure will be able to achieve this goal. What we expect is this is going to improve the patient and the staff safety, and reduce medical legal exposure for the because lakhs of compensation are paid whenever the safety is of the patient is compromised, and also lakhs of money is lost in refurb whenever the MR is quenched. And we have to reach to a global benchmarking alignment, because several countries, especially in the Europe and the US, are far ahead in MR safety. And this will also, when we do the national impact, strengthen the role of IRA leadership in such an important cause that we are going to take up. So MR safety is a shared responsibility. Structured roadmaps ensure uniform standards, and policy plus training plus monitoring is going to lead to a safe MR ecosystem. And it is high time that we implement it nationally. Thank you so much for the opportunity.
Thank you, Dr. Murali Krishna L., President-elect of Indian Radiological and Imaging Association, and also the Executive Counselor of in charge of the Education Committee of Asian Oceanian Society of Radiology. That was a wonderful lecture. You have really highlighted the important points, and the roadmap is very, very, very detailed. And I think this is if the future leadership of IRA and AUSR can take it forward, it's going to make a huge impact for MR safety in India. Thank you, Dr. Murali Krishna, once again.
Thank you.
Now we will move on to the second session, academic session. As part of this webinar series, apart from the country focus, we want to bring in all the stakeholders of MR safety and to hear their perspectives also. And that is why an MR technologist, who is an MRSO, MR safety officer in Sri Chitra Institute of Medical Sciences in Trivandrum, Kerala, India. She is joining us. She's a technical officer and with a 25-year experience as MR technologist and a member and faculty of the Indian Society of Radiological Technologists. Mrs. Sheeba Kumari, she will be joining us for this session on implants and screening, a technologist perspective. Welcome you, Mrs. Sheeba Kumari. Over to you.
Thank you, sir. Thank you for inviting me to speak. So in this topic for MR safety of implants, I'll be covering the basics implant interactions in MRI and the scanner conditions. So why the implant safety matters? The implant diversity, it is increasing, and in daily we are encountering many patients with implants. And we also have the fatality reports in front, like when we scanned unknown implants or unsafe practices. At times, denial or delay in examination in patients with implants can have huge impact on their treatment prognosis and survival. So now the heart of MR safety is safe scanning of patients with implant. For that, what we have to do is we have to understand what are the possible device interactions in an MRI, and what we have to understand the scan conditions, and then we have to apply it precisely. So the implants, they are classified into passive implants and active implants. So the passive implants are the mechanical device which are attached to the body. They don't have any electronic components. For example, joint replacement, aneurysm clips, heart valves, and vascular stents. Often their metallic components make them incompatible or contraindicated in MR. They may produce tissue artifacts or tissue heating. So coming to the active implants, they are the devices which have the electronic components. They have battery, leads, circuitry, and electrodes. And these electrodes are often implanted in the critical part of the body. For example, the neurostimulator, it is having its leads implanted in the subthalamic nuclei or the globus pallidus, whereas the pacemakers were having its leads implanted in the myocardium. So these devices directly controls the patient's functions and well-being, and the potential hazards to these devices in MR are device malformation, therapeutic inhibition, the heating of lead tip, battery depletion, and device reprogramming. So an implant can have many interactions in an MR environment. The static magnetic field attracts these implants towards with a strong force. We call it as the attractive force. And if the implant is elongated and it is ferromagnetic, the north-south pole of these devices try to align with the magnetic field, that is the torque force. The gradient magnetic field can have the implant the tissue, the heating and electric current invention and vibration that this gradient switching can produce. And the RF, the important concern is the heating. So the severity of these effects of these all interaction, it depends upon the field strength, what is the spatial gradient of the magnet, what is the mass of the implant, shape and geometry, and the magnetic susceptibility of the material. So an implant can have its maximum attractive force near the pole pieces where the static field, magnetic field gradient is higher. So the force of attraction, it is directly proportional to the B0 into the spatial gradient, whereas the torque force will be highest at the center. And usually the ferromagnetic implants, that is the implants which are made up of cobalt, nickel, martensitic steel, mu metal, pure iron. These are the ferromagnetic materials. They can have strong attractive and torque forces in an MR environment. And these devices are unsafe to scan in MR. Whereas the modern implants, which are made up of titanium, nitinol, platinum, alloy, phenox, palladium, cobalt, chromium, molybdenum, the attractive forces on these devices are negligible up to 3 Tesla. Then another concern is whether these implants, they are fixed or free. If the implant is fixed to the body, they will be anchored by the tissue holding forces. So if they are encapsulated by fibrous tissue or if they are surgically fixed, they do not move in the MRI because they will have the tissue holding force and the magnetic force never attains its threshold more than the tissue holding force to move these devices. Whereas the implants which are attached to the soft tissues, for example, the aneurysm clips which were manufactured before 93, they will have some ferromagnetic content, so they are attached to the blood vessel. If they move, they will produce SAH and severe damage, severe impact on the patient. The same way, the foreign bodies near the vital anatomy, that is either near to the optic nerve or near to the spinal cord, can have serious injury. Another concern regarding the radio frequency pulse is the RF pulse induces the electric currents and it can cause the localized tissue heating and thermal injury to the surrounding tissue. And the amount of heating, it depends upon the implant length, size and shape, orientation and the material composition. The implants which are made up of titanium and stainless steel implants, they heat less in an MR environment because these thermal conductivity of these devices are very less, so they heat less than the diamagnetic implants. And also the concern is that where this implant is located within the RF volume, whether the devices which are located inside the RF volume heats more than the devices which are outside the RF volume. Same way, the implants which are located peripherally, which heats more than the implants that are located centrally. So also the implant which runs parallel to the RF coil, that will experience more coupling and RF heating than a perpendicularly oriented implant. The RF heating also depends upon how much tissue perfusion, implant location, and also the age. If an area is having good perfusion, for example, the vascular implants and the implants placed inside the heart, they will have the blood cooling effect by the blood, so that these devices heat less than the less. Also, the embedded implants, they will have the protection of conductive heating, heat dissipation by the tissue. So the embedded implants heats less than the externally fixed devices. In pediatric patients, their heat dissipation is higher, and we use lesser RF pulse in these patients. So the pediatric patient, the heating concern is less compared to the adult patient. Coming to the most important concern with the RF pulse is its resonant heating. So when the implant length matches the half the wavelength of the radio frequency pulse, there will be perfect coupling forms between the radio frequency pulse and the implant, and resulting in a sudden rising temperature at the lead tips. And this is called the resonant heating. So the resonant wavelength of this radio frequency pulse will be modified by the dielectric property of the tissues, and also it depends upon the field strength. So for example, in muscle, the resonant wavelength for RF pulse at 1.5 Tesla will be 27.6 centimeter, and at 3 Tesla it will be 14 centimeter. So a 27 centimeter implant will be more safe to scan at 3 Tesla than 1.5 Tesla. Of course, all the metal implants, they will produce artifacts. They distort the field. They cause the geometric distortion of the field, and sometimes these artifacts are large enough to impair the diagnostic quality. And these artifacts, it depends upon the type of material, and the titanium implants heats lesser, produce less susceptibility artifact than the cobalt chromium implant. And also the artifacts are less with 1.5 Tesla than 3 Tesla. Then we have to prefer spin echo for the implants cases than gradient echo. Dixon-based and stir-based fat suppression technique than the chemical-based suppression. And we can use the metal artifact reduction technique which are provided by the vendor. And also the good technologist is he can do various the parameter adjustment to mitigate the susceptibility induced artifacts, and the radiologist who is interpreting the scan implant scan should know about the implant artifact for the accurate interpretation. So coming to the classification of implants, the American System of Testing in Medicine, they classified all the implantable devices into 3 categories. That is MR safe, MR conditional, and MR unsafe. And MR safe item means if the device it is non-metallic, non-conductive, and non-ferromagnetic, and this poses no potential risk to the patient in all imaging MR environment. MR conditional means that they are safe only under defined conditions, and MR unsafe means the item poses significant risk in MR environment, and we should not take into the MR room. So the conditions, the key condition to verify are: one is the confirm the field strength, what is the spatial gradient, the transmit coil type, patient position, what's the specific absorption rate, the gradient slew rate, and the B1 plus RMS condition. And the device must be scanned when all the scanning conditions are met. With the partial compliance, we should not do the implant scanning. So the condition regarding the static field means that it will be specified as conditional up to 1.5 Tesla, up to 3 Tesla or 3T only. A device which is conditional up to 3 Tesla means we can scan either in 1.5 Tesla or 3 Tesla or lower system, we can do it. But once it is condition specified as 3 Tesla only means we should not scan at lower Tesla, because we know that the resonant heating doesn't scales with the field strength. So the conditional at a higher Tesla doesn't guarantee its safety at a lower Tesla. So there is one case report of when there was an neurostimulator which was conditional up to 1.5 Tesla, scanned at 1 Tesla and created so the heating, localized heating and brain tissue damage. So the condition in implants there, at times it will be marked an exclusion zone. So we should not, maybe the leads or the battery will be placed here. So we should not scan this area. This will be, and also the transmit receiver's coil, if we are using, we should not place directly over this area. And in modern all MR systems, the RF transmission is done by the body transmit coil. Only we are placing the receiver coil directly over the patient body. So understanding the spatial gradient condition. Usually in all device, it will be mentioned that condition, that is, it should not be exposed to more than 720 Gauss per centimeter. So how we'll analyze these conditions? So every MR machine, it will be provided with a static spatial gradient map. So with the patient lying on the scanner, so we can analyze this graph. It's a measure of the non-uniformity of the magnetic field at the bore. Actually, the magnetic field will be uniform at the center. Coming to the periphery, it will be varying. That is what we call it as the spatial gradient. So by analyzing this graph, we will be able to know that where when patient is positioned inside, where this implant will come. So here we can see that the patient maximum, the spatial gradient exposed will be 7 Tesla per meter. That is 700 Gauss per centimeter. So this device can anyway, we can safely scan with this machine. So coming to the SAR, that is the specific absorption, that is the amount of RF energy that is absorbed by the patient body. And it is calculated according to the patient body weight, and then it is expressed as watt per kg. And this is a measure of RF energy absorbed by the body, and it varies with the patient tissue type and composition. And so it's not an accurate measure, and there's not a universal standard it's not a universal standard. So it doesn't guarantee the RF heating, but we can use this as a guidance. Then the SAR calculation, it is directly proportional to the square of frequency, flip angle, number of echoes, number of slices, and it is inversely proportional to the pulse duration and TR. So when we take an implant to the MRI, there is IEC provided fixed operating mode. In every MR system, we have the fixed operating mode. So an implant scanning should be done in a normal operating mode, where all the scan parameters will be limited to 2 watt per kg. So that if at sometimes we may need to have scanning done at the first level mode, so we have to restrict imaging and we have to carefully monitor the patient. And the second level mode is not recommended for any clinical implant scan. So we have several methods to bring the SAR value to the preset or recommended required level by adjusting the scan parameters, that is by decreasing the TR, reducing the flip angle, limiting the number of slices, limiting the number of echoes, using concatenations, alternating the high SAR and low SAR sequences, and allowing to cooling between the sequences and also controlling the room temperature, humidity, and using the light clothing for the patient. The B1 plus RMS value, which is the most accurate method for calculating the RF injury to the patient with the implants, and it is actually calculated as the square root of SAR. And the B1 value, it is not the amount of RF absorbed by the body. Instead, it is the magnitude of the RF that is generated by the transmit coil and that is transmitted to the patient. So it's a better accurate method for the active implant to assess its safety. So the unit will be in micro Tesla. The 1 micro Tesla at B1 plus RMS value at 128 megahertz. It will be specified with the frequency. So 1 micro Tesla B1 plus RMS value at 128 megahertz induces double voltage compared to 1 micro Tesla B1 plus RMS at 1.5 Tesla. The gradient slew rate condition. So this device, all devices will have this gradient slew rate condition. It actually slew rate means how fast we are switching our gradient on and off. So the maximum gradient strength of most of the implant scanner, it will be limited to 200 Tesla per meter per second. So whenever we are taking a patient with the implant for scanning, we can select the normal gradient operating mode or the implant mode, so that the scanner parameters will be, or the gradient switching will be limited to the gradient limited to a preset value. So where we will get the safety information, reliable safety information regarding a particular implant, and where we'll get it. So we can, the best is to identify the device and go for the manufacturer's website. And also we can use the database, the mrsafety.com, the magresource.com, and also if we didn't get sufficient information, we can check is there any scientific publication to support the same scanning of these devices, whether they have done any scanning with this implant. So the future of MR will be, so now that leadless leadless devices are coming. So the leadless pacemaker has come to the market, and battery-free implants, and that is under research. And also we have some, in MR we have some implant mode selection, so that the AI-assisted implant mode selection will guide you to adjust the parameters to the implant limit. So by concluding, with a structured and optimized way, we can do the implant scanning safely in MRI. So we need to do the proper screening, thorough understanding of the device, and we have to optimize the MR scanning parameters. Thank you.
Thank you, Ms. Sheeba Nair, Sheeba Kumari, the MR Safety Officer and technologist from Sri Chitra Institute of Medical Sciences, Trivandrum, for a wonderful lecture. She has given in detail. Of course, if anyone asks me what is the most difficult part in MR safety, I will always say it is implant related screening, because this is where a lot of challenges are there. And know whether now in the arrival of increasing neuro, cardiac, and ortho implants coming up, maybe the newer ones are more MR conditional, but the older ones we need to screen for them. And Ms. Sheeba Kumari has given us a larger perspective of a holistic perspective of implants. And thank you, Ms. Sheeba Kumari. We will come to the questions at the end of the session. That was a technologist perspective on implant screening. Now we will hear a very short perspective for 5 minutes from a radiologist, that is Professor Dr. Amel Antony, who is the head of the department in the Lisi Institute of Imaging and Research at Cochin in Kerala. Dr. Amel Antony will talk to us on the radiologist perspective And this will be a collaborative one, a short one, supporting because Sheeba as a technologist has covered a major part of the implant screening. Over to you, Dr. Amel.
Thank you, Dr. Rijo. It's a great effort with this India-specific MR safety call for action series, what is going on here. And congratulations to ASR and Rijo in particular for this initiative. So starting from where Mrs. Sheeba Kumari has concluded, the radiologist's role is multi-pronged. We have to understand that the MRMD or the radiologist in charge is the custodian and the key person, or I would say the last post to decide on MR safety as far as implants are concerned. Because after taking all these inputs, it's the radiologist who should take the final decision as to decide whether this particular implant is MR safe or not. So for that to happen, MR department, all departments should have a written safety policy. And obviously all these identification, documentation, and all those things have to be done, which happens with the presence of MRSC and MRSO and the technologist in charge. And as emphasized by Sheeba Kumari, once again, never assume MR safety of any implants, and identity and the model is very important. And whenever we are in doubt, a team should go in and do a risk benefit analysis. So that includes the clinician who has referred the patient, the radiologist, and any other department which is involved. Together with the technologist or the MRSO, one should take a group decision as to whether the risk is much more than the benefit or the other way. And informed consent is very important. And most important, we have to ensure that the pre and post scan, the implant is working. So this is just an MR implant safety workflow. Whether implant status is not known, routine MR safety screening, and then you go ahead with the MR, and implant status is known. Go into the device name specifications, MR technologies reviews, MR conditional. You're not sure, then the risk benefit analysis is done. Conditions can be met, it cannot be met, again risk benefit analysis. And if conditions can be met, one can go ahead with this. And two most important things which we come across are cardiac pacemakers and DBS. And cardiac pacemakers, we know that now we have pacemakers which are even compatible with 3 Tesla. The most important thing is the electrophysiology technologist or the electrophysiology trained cardiologist should be available to reset the pacemaker before and after the scan. And as mentioned again, if it is MR conditional, all the conditions specified by the vendor has to be met so that it's a safe scanning for the patient as well as for the equipment. As far as DBS is concerned, always the question arises whether this particular scan is required, especially if it's brain. Is there any other choice? And if it's for some other conditions outside the brain, always one should consider alternative imaging modality. And obviously one has to monitor for acute adverse effects and ensure that impedance stability is there. And risk benefit analysis, just to emphasize it once again, it's a clinical decision, so case by case. And it depends on the strength of the MRI availability. If there is any alternative imaging modality, we should go for it. And one should decide whether this information is diagnostic and useful, whether it's going to change the management of this particular condition. And as emphasized, clinician, MRMD, MRSC, MRSO, and the MRI technologists are all part of this multidisciplinary team. And another important point is if something happens, there should be a system to manage the risks. An important component is the environment and the personnel. That means the environment should be conducive to managing risks. Appropriately trained personnel should be there. Appropriately trained or appropriately assigned space should be there. And proper implant workup, risk benefit analysis, protocol and parameter modification, and active monitoring of scanner outputs, and specialist support, especially when we are dealing with cardiac pacemakers and other ICDs, cardiologist availability, emergency team in position, and as emphasized, electrophysiology technologists for resetting the equipment. And also more important, MR compatible monitors should be there. Resuscitation room should be just adjacent to the MRI suite, and a defibrillator should be at hand. So I don't have to emphasize much on this. Documentation is very important, starting from risk-benefit analysis and the details of the implant. All these have to be clearly documented because this carries a lot of weight. I mean, if at all something happens to the implant or to the patient. So to emphasize once again the challenges which we have already, Dr. Murali has specified this. There is absence of a comprehensive national implant registry here. We always have incomplete documentation, especially in EMR systems. Then patient awareness is quite less, and more newer implantable devices are coming into the market, making it much difficult to keep pace with the details of the various implants. And as mentioned, increasing number of 3 Tesla scanner installations are going on across the country, and we do not have an India-specific MR safety guidelines, of course, which will come in future, and varying practices between institutions, and of course the other financial constraints which can limit the use of MR conditional devices. MR compatible monitoring equipments may not be there in standalone scan centers, and the lack of MR safety trained personnel. All these are all limiting factors. So in conclusion, I would like to say that implant safety screening and monitoring and ensuring the safety is a teamwork. There should be a dedicated team starting from MRMD, MRSO, MRSE, and the technologists in association as required with the referring physician. We should have a protocol in place. We should have a checklist in place, and we should have a clear understanding of what implant means, especially as emphasized by Sheeba Kumari, active implants and passive implants, and when we can take up these cases for MR after installation of these implants, especially if it's a passive implant. And if it is MR safe, maybe you can do it the very next day or immediately after the surgery. But if it is active, it depends on the make, at least 4 to 6 weeks, one may have to wait. So it all depends on the specifications which are mentioned by a particular vendor. So it's a team effort. And as a radiologist, as MRMD, has to take the lead and ensure that the systems are in place. Thank you.
Thank you, Dr. Amel Antony, for sharing the radiologist perspective. What we heard right now was the technologists and radiologist perspective on implant. Most challenging segment in MR safety is the implant screening, and the technologist perspective and the radiologist perspective has been shared. And I thank both of you for that wonderful lectures shared with us. You've given a lot of inputs. I'm sure our audience might have taken notice of all the points that is. Now we will move on to a panel discussion. This panel, so we have a lot of guidelines coming in. If you look at it, the ACR guidelines are there. So many webinars has been conducted. So many important sessions has been conducted worldwide, and even AsiaSafe and AUSR has conducted so many sessions on MR safety. But what is, we need some action on the ground. I've been talking about it in the last webinars also. Action is what is required at every institution, at every country. Motivational talk or a theoretical talk won't lead to MR safety. That is why in MR safety accidents are increasing. It's not only because MR installations are increasing, not only because the challenges related to implants and all these things are there, but the MR safety action plans, time-bound action plans, we are lacking. So we are making an attempt here to bring out an action plan on a zero tolerance approach towards 3 major MR accidents. And along with me, as panelists in this session, I have with me Dr. Pradosh Kumar, who is from the Department of Radiology in All India Institute of Medical Sciences, Deoghar, Jharkhand. He has been leading the MR department in interventional radiology there ever since the institute has started. And for MR safety initiatives in the particular department, he has made a lot of efforts. I will share that as the panel discussion progresses. The other panelist here is Dr. Rishmi CP. She is a senior consultant at Anandapuri Hospital Research Institute and Gigi Hospital in Thiruvananthapuram. And she has got a special interest in abdominal radiology, head and neck radiology. Thank you, Dr. Rishmi, for joining today, and we wish you a happy birthday. And the third panelist is Dr. Suvinay Saxena. He is from Bhopal, an assistant professor with Chirayu Medical College and Hospital. And Suvinay Saxena is also our AsiaSafe License Committee member for India. And I'm sure the young radiologist as the AsiaSafe Licensing Committee member will play a significant role to spearhead the movement of MR safety in India. The next panelist is the Secretary General of Indian Radiological and Imaging Association and also an additional professor at the All India Institute of Medical Sciences in Rishikesh, Dr. Pankaj Sharma. Can I have all the four panelists here? I will briefly start the I'm just sharing my screen. So if you look at the MR accidents, so zero tolerance for three major MR accidents. Why we have taken these three is because thermal events or the burns constitute to 59% of the MR accidents. Next is the projectile events and the medical device malfunction. These three together forms more than 80% of MR accidents. And if we can have a zero tolerance approach towards these three, I think we can win this war against MR accidents and make MR much more safer. To begin this, I would like to have, as thermal burns is a major MR accident that we want to have a zero tolerance approach, I would like to invite our panelist, Dr. Pankaj Sharma, the Secretary General of Indian Radiological and Imaging Association, to talk to us on what are the causes of the thermal burns and how can we prevent it.
First of all, thank you, Dr. Riju Mehta, for giving this opportunity. This is a very important India-concerned initiative by USR. And as regards thermal burns in MRI, this can be caused by many causes. Like first is metallic objects like watches, jewelry that can heat up due to RF frequency energy. Then implants, as already Sheeba has covered extensively. Then conductive loops, like loops of skin, clothing, or cables that can create a conductive pathway for radio frequency energy. Skin to skin contact, direct skin contact with another person or object that can cause heating. Then radio frequency calls, if they are improperly positioned or malfunctioning radio frequency calls, that can cause localized heating. Then tattoos or permanent makeup, very important these days, which can cause heating or burns. So because certain inks or metallic components are responsible for this. And then in medical devices, certain medical devices like ECG leads, pulse oximeter, other monitors that are not MRI compatible. So being aware of this potential risk can help prevent thermal burns in MRI scans. And technologists and radiologists are important part of this chain who can screen this and reduce the chance of thermal burns. Then if we talk about the methods, the precautions we can take to avoid thermal burns in MRI, then we can follow these precautions. First is most important is screening. Identify patient with implant devices or objects that can cause heating or burns. Second is radio frequency padding. Use radio frequency absorbing pads to prevent skin to skin contact and reduce heating. Third is coil spacing. Ensure proper coil placement and spacing to minimize radio frequency energy deposition. Fourth is patient positioning. Avoid loops or folds in the patient body that can create conductive pathway. Jewelry removal, very important. Remove all metallic objects, including jewelry and accessories, before taking patient to the MRI room. Then implant verification. Verify implant compatibility and safety using manufacturer guidelines or MR safety database. And Sheeba has extensively covered this important topic. Then monitoring. Continuously monitor your signs of heating or discomfort during scanning. And there's SAR limits. Adhere to specific absorption rate limits for radio frequency energy. By following these all important guidelines, we can minimize the risk of thermal burns in MRI scans. And proper training of technologies and radiologists is more important in this pathway.
Thank you.
I think we automatically follow these guidelines. then we can avoid a lot of preventable thermal burns in this patient.
Thank you, Dr. Pankaj. Pankaj has elaborated on the causes and how we can prevent the thermal burns, and the full stop checklist that is available in the ACR manual. And this is one very important resource that all of you should follow. That is the ACR manual on MR safety. The 2024 update and revisions in 2025 are also available on the net, free to download. Now, let me move on to the next panelist, Dr. Rishmi CP, on what are the causes of the projectile or the missile accidents, and how can we prevent it?
So this projectile accidents is one of the most lethal accident that can actually occur during an MR. So why this projectile accidents occur? Because you know that we have this 1.5 or a 3 Tesla, which are commonly used MR, and we have a static magnetic field. So in 1.5 Tesla, the static magnetic field is around 21,000 times stronger when you compare with the Earth's magnetic field. So, and that is always on. So that is the main point that I want to highlight here. The static magnetic field is always on. So that awareness should be given to all the people which are related to the MRI, the technician, the staff, the patients. So they have to be aware that any ferromagnetic objects can be strongly attracted towards the static magnetic field, and it will be in such a manner. So the Mrs. Sheeba Kumari has explained the static magnetic field, the gradient, and how these ferromagnetic objects are attracted towards the magnet. So in the previous slide, actually, you can see there are two types of forces, which is already explained by Ms. Sheeba Kumari, which is the translational force, which is actually causing this missile effect. The projectile effect is also called the missile effect. So why missile effect is that all these ferromagnetic objects will be attracted like a missile. So we are not getting time to prevent it. So just it is within a certain distance of the magnet, it is strongly pulled towards the magnet, and we can't actually prevent it. So that is the cause of the projectile accidents. So and why this happens is that it's basically because of the inadequate screening. So it's not a technological fault which is happening there. It's mainly due to a human oversight or a system failure. So that is the most important thing. So how can we prevent that? It is basically due to a proper screening, and zoning is very, very, very important. So we have a slide on the zoning where there are actually 4 zones. So that is very important. Zone 1 is the public interface, where the general public is sort of a waiting area. So all these zones should be clearly labeled in front of the MR machine. So zone 1 is the public, like everyone is free to come there. Zone 2 is actually a supervised screening area, actually where the patients and the bystanders can come in, and there actually we screen the patient. So we have a double level screening. So double level screening means first we give both, there is a verbal screening, and we actually give a written screening form also. So there is a written as well as verbal screening, and after screening, so there is a big list of the screening protocol is there. It is freely available. So there is a huge list. We have to screen each and every point of it. I think actually Amel sir and Sheeba Kumari is actually they have actually noted all the points. So after screening, only the patient will be allowed to enter the zone 3. Zone 3 is basically the restricted access or the control room, where actually it is actually a biometric access. It should be the access should be controlled either using a biometrics or a card, so that only the screened personnel or the MRI staff which are trained in MR safety is allowed to enter. After that, before the zone 4 is the area where the MR is being done. And before entering the zone 4, there is a final checklist or the full stop, where the level 2 MR personnel actually double checks all the safety procedures. He again asked whether there's a metal implant. So all these questions are again asked, and then only the patient finally enters the zone 4. So this zoning is very important to prevent any projectile accidents. And the next red flag that usually comes during an MR, which leads to a projectile accident, is a panic situations like a code blue. The patient suddenly collapses within the MR room, and the staff in panic actually with the crash cart enters the MR room. So that is again very, very dangerous. So in those areas, the patient should be actually pulled out of the zone 4, and then all the registration should be started outside the MR room, and the MR safety officer should be called. And the most important point is never bring the crash cart inside the magnetic room. And the next red flag is for the ICU patients or the patients with anesthesia. They have actually a lot of things which is they carry along with the patients, and all those things should be kept in the zone 3 or a zone 2. And all this MR labeling is very important, and all these portable devices, we have to see whether it is MR safe, MR conditional, or MR unsafe. MR safe can be easily carried inside the MR room, and especially in a tertiary care center, we should make sure that all are MR compatible. We should have the MR compatible anesthesia equipment, MR compatible ventilators. So everything is very important. We should not take any other machine outside. So this labeling is very important, like MR safe, unsafe, and conditional, and we should actually screen it again before entering all these entering with these devices into the MR machine. And physical tethering, that is an important concept which actually it is explained in the new ACR guidelines. So all these MR unsafe or unconditional items, especially the anesthesia machine, should be physically secured and anchored in the zone 3. And it should not enter the zone 4. If at all in the zone 3, it should be properly anchored. So physical tethering is also very important for this MR unsafe or MR conditional items. And we should use this ferromagnetic detection system. We can also use a handheld magnet to check that these patients have these portable machines or any other machines or devices before entering the MR, that is the zone 4. So this is the MR projectile accident prevention policy. This is the action plan. So this access control is very important. The zoning is very important. Mandatory screening, there is no exceptions for that. Everyone who is entering zone 3 should be screened, whether it's a staff, cleaning staff. So that's also very important, because cleaning staff is often unaware of the importance of this MR safety. So all the staff, so whenever an MR is installed in a hospital, all the staff, which starts from the doctors, the critical care team, the emergency team, the nurses, the cleaning staff, all the technicians, everyone should be trained before starting an MR installation in the hospital. So this training is very important, and the awareness should be given to all. This equipment control policy, that is basically the MR safe, unsafe, and conditional, we should actually follow that. And we should have a trial for this high risk situation, especially if the patient collapses, if the patient suddenly has a breathing difficulty. So all this should be there, a proper policy should be there. And whenever the patient arrives in zone, so this is actually the step that we follow in a hospital. If a patient arrives in zone 3, the screening form is completed, the final verbal cross-check by the level 2 MR personnel. And finally, if any metallic object is detected with the ferromagnetic detection system, that should be removed, and again the patient should be rescreened. And then if there is something abnormal, they have to go back to the zone 1. But if nothing is there, they can proceed to zone 3. And it is the equipment required according to these MR safe, it is allowed, conditional, you have to see the limits, and unsafe, it is stopped. So then only there is the final stop and the patient enters the zone 4. So these are some of the things that we follow in a hospital.
Yeah, thank you. Thank you, Dr. Rashmi. Now we will move on. So this is an MR safety pyramid. I just want to explain to all the listeners here. This gives a very comprehensive understanding about instituting MR safety in your institution. Your mission has to be very clear, and your team has to be comprised of an MRMD and MRSO. And MRMD is a radiologist, and MRSO is a technologist. The MR safety committee, preferably to form an MR safety committee at your institution to formulate an MR safety policy. And these are the 5 components: the training, screening, the MR systems and environment, protocols and processes, and incident reporting system. So this triangle, this pyramid with all the 5 components, if you can institute in your MR center, it will benefit the cause of MR safety. Now I will move on to the next panelist, Dr. Pradosh Kumar Sarangi. In the previous webinars, I had asked the listeners to send me videos of what they're doing in with regard to MR safety in their institutions. They just showcase their MR safety practices, and I'm extremely happy to share the video which was sent to me by Professor Pradosh Kumar Sarangi from Yoga.
My name is Orpita Ghosh. I am working as an IT officer in the Department of Radiodiagnosis in India. In this year, we have celebrated the MRI Safety Week in last week of July. This year, we have conducted an interactive MRI Safety Awareness program for the faculty, residents, planning officers, hospital attendants, and for students also. After this session, we are better oriented towards patient MRI screening, especially implant screening. Various MRI implant levels include MRI safe, MRI conditional, MRI unsafe. In this MRI Safety Week, we also learned the importance of MRI zones, pre-visit safety screening questionnaires, and thereby making the MRI examination a positive experience for the patient, for the technologists, and for the other staff in the department.
मैं शुभम दत्ता, रेडियोग्राफिक टेक्नोलॉजिस्ट। नर्सिंग स्टेशन से पेशेंट जब हमारा जोन 3 में आ जाता है, सर में वॉक थ्रू मेटा डिटेक्टर से हम पेशेंट को चेक कर लेते, दोबारा स्कैनिंग करते। उसके बाद कोई भी पेशेंट का अंदर अगर मेटा है तो उसका एमआरआई सेफ्टी लेवल चेक करें। पेशेंट का रिकॉर्ड में सेफ्टी लेवल का कोई मेंशन नहीं है तो उसके लिए हम डेडिकेटेड एमआरआई सेफ्टी पॉइंट साइट में उसका सेफ्टी लेवल चेक करते हैं। मेटल इम्प्लांट ट्रॉली व्हीलचेयर एमआर सेफ है, कोई सिर्फ जोन 4 में अलाउड है।
अंदर लेने से पहले पेशेंट को हैंड मेटल डिटेक्टर से चेक करने के बाद ही पेशेंट को अंदर भेजें। ये हमारा गैस ग्रुप है, मैग्नेट हमेशा ऑन होता है। इसके अंदर तरह का मेटल ऑब्जेक्ट्स लेके नहीं जाना है, लाइक बोर्ड इम्प्लांट, पेस मेकर, स्किन क्लोथ, फायर एक्सटिंग्विशर, ये सब कोई भी डिवाइसेस, मेटल डिवाइसेस अंदर नहीं जाएंगे। हमारे इंस्टीट्यूट में हमारा प्रोग्राम किया गया था, इसके बाद से no radiography technologists और भी ज्यादा कॉन्फिडेंट है ऐसे प्रोग्राम्स frequently all the units of the to ensure the safety of patients and other staff.
Hello everyone, we are from the department of radiology. I am Dr. Santosh. Along with my introduction of Dr. Kumari, where I will be application and technology. We conducted an MR Safety program on where we chastise our hospital officers, our patients, our hospital attendants. And this program, we want to be of that. We are committed to our safety. So let's again.
So that was the beautiful video that was sent to me by Professor Dr. Pradosh Kumar Sarangi. Pradosh, I'm coming to you.
Thank
This
you,
is
sir.
an action plan for zero tolerance against 3 major MR accidents: projectile accidents, thermal burns, and implant failures. So within 1 year, 12-month roadmap, how do you plan to execute it? And can you please go into the details of it?
Yeah, thank you, sir, for inviting me for this session. So this is actually a 12-month plan. So this is action plan. So we have to do some actions. It's not like just like a theoretical plan. So in this 12-month plan, so we have done breakups for 5 breakups. In the initial 1 to 2 months, we have to do the risk assessment. So in your existing system, what are the risks in your system? Basically, the first phase is you have to check a policy and you have to see whether you are following that ACR zones, the 4 ACR zones, the mapping, zone 1, zone 2, zone 3, zone 4. So first phase is the risk assessment and policy update. In the second phase, third to fifth month, we have to do the training of the staffs. Basically, the training of level 2 staffs, those staffs which are directly dealing with the MRI, the nursing officers, the radiologists, the technicians. So training of these staffs. And
hands-on projectile drills and burns prevention schemes, and daily checklist for the implants. So this is in the second phase, that is the months 3 to 5. In the next month, 6 to 8 months, the focus is 100% screening. So screening of implants is the main focus in the third phase. So for that, we have to install that detectors at the entry of the gantry, and we have to verify the implants using some specific apps or the MRI Safety website. In the next month, the main focus is we have to see whether these things are happening smoothly or not. So main thing is the audits and drills. So drills basically you can do bi-weekly, and the emergency response should be less than 30 seconds. If anything happens in the entry room, let's say there is a fire or some actual hazards, so response should come within 30 seconds. So that is the main focus in the fourth phase. So rapid response is the main focus in the fourth phase. In the last month, so we have to build the culture. We have to sustain the things which we are following for the last phases. So we have to maintain that there should be zero events and staff surveys, and the MR department should be externally accredited by some society, let's say our AOSR or IRIA. That is the last phase. The external accreditation is the last phase. So that's
Thank
this
you.
is how we're planning, sir.
Yeah. Thank you. So it's a very detailed explanation to this 1 year or 12 months action plan for zero tolerance. Thank you, Dr. Pradosh.
Thank you,
I
sir.
have with me one more panelist here, Dr. Suvinay Saxena. He is the AsiaSafe Licensing Committee member for India on MR safety. So my question to Dr. Suvinay is, how do you plan to execute the zero tolerance action plan and the MR safety initiatives in India for the next year? Do you have any roadmap for it?
Very good evening, sir. And my job has been made quite simple by the previous speakers. So we have had a lot of roadmaps from including Dr. Murali Krishna, sir. He had already highlighted a 5-year plan, and Dr. Pradosh also beautifully highlighted a 12-year plan. So what we can do as an idea, or how to get it at the ground level, is first, as everyone has already talked about MRI safety zones, it should be implemented strictly. What we can do is, many hospitals have RFID tags. So when we use RFID tags on patients, we can track the patient from whether the patient is in zone 1, 2, 3, 4. That can be enabled inside the MRI console, and the operator is already always aware where the patient is. We can have smart MRI suites. Everyone talks about AI. Why not use AI to help monitor, detect metallic objects, also monitor patient vitals immediately if something goes wrong, and alert of the potential risks. 3D MRI safety training, including virtual reality or augmented reality simulators. That can be done. If we cannot exactly replicate the true situation, at least create a virtual reality or augmented reality situation and train the staff for the same. Like my previous speaker, Dr. Ashmi, talked about code blue. Why not have a code blue for our own MRI safety? Is like we are trained for ACLS and BLS. Why not train all the staff for how to do how to perceive such a situation and prepare themselves? Also, very important is to give patient education, provide interactive tablets. We can train the patients on how to go about MRI safety screening and procedures. Apart from the staff, it is important to make it readily available for the general public. And what we can do as local IRI bodies throughout the country can conduct small events. Similarly, train the residents, train the general staff about this. And the next 5 points include, obviously, we know about metal detectors. We can have standardized MRI protocols. MRI safety apps can be given to the staff so that they can use a checklist in their for them. You can have safety guidelines, emergency protocols inside the apps. Regular safety drills has already been highlighted by Dr. Pradosh, and safety certification definitely would be the need of the hour, to have standardized societies including AOSR and the IRI to come up with mandatory certification of the technical staff and the doctors. Some out of the box ideas may be We can have a safety leaderboard throughout the country. Why not give rewards to the institutes who are doing very good or adhering to the staff safety protocols? Maybe develop AI algorithms to analyze MRI in real time and and assess potential safety risks. Like we have hackathons in IITs and engineering institutes. Why not have our own hackathon? Why not create innovation and collaboration with engineering institutes to provide MRI safety solutions? So from my side, this would be the input, sir. Maybe it is time.
Thank you, Dr. Suvine. That was a young mind who has integrated AI and all the out-of-the-box ideas to implement. And we're looking forward, Suvine, for more activities from you to implement this zero tolerance action plan in India with more and more activities that will be, I'm sure, will be lined up all over the country soon. Thank you, Dr. Suvine, and thank you all the panelists here for contributing towards the zero to action plan for zero tolerance towards three major MR accidents because they form the bulk of MR accidents: thermal burns, projectile accidents, and the implant device malfunctions. So if we can put a zero tolerance approach towards that, I think half a major battle towards towards avoiding MR accidents and to implementing MR safety, we will win. And I'm sure this momentum, let this panel discussion be an inspiration for everyone who has listened it to implement the zero tolerance culture against these three major accidents in their MR centers. Thank you very much, all the panelists, Dr. Pradosh Kumar, Dr. Subhine Saxena, Dr. Rishmi Sikri, and Dr. Pankaj Sharma, the Secretary General of Indian Radiological and Imaging Association, for joining in. That concludes the academic session. Now we will move on to the question answer session. We'll take up a few questions. Before that, I have the president of AOSR here. Request the president to give some comments on the academic sessions.
Thank you very much. That's very impressive presentation from all and in all aspect of the MR safety. I think it's very important that all the stakeholders join together. The video that has come up is very, very nicely done, and it showed the collaboration of the teamwork, right? I think to make the MR safe, you need a lot of teamwork, as today panelist has shown us. And I'm looking forward for the more countries to join. And Dr. Rachel, compliment to you that you just bring in so many expertise and all the point, especially on the technologists. That I think is very, very impressive. The radiologists, even you are all the leaders, but I have recognized it in the you recognize other team members as important as you yourself. Thank you very much.
Thank you, President Dr. Chamari. And may I have the chair of AsiaSafe, Emeritus Professor Kwan Hung Ang is with us. Sir, some comments from your side.
Hi, can you hear me?
Yes, sir.
Okay, good. I just joined the last part. I have a different meeting to attend. It's excellent. The team India, I must congratulate you, and all the whole world be watching on you. See how you progress the next 3 to 5 years, and after this, other countries will be presenting as well. So you have set, I should say, a benchmark for the rest of Asian countries to follow or to learn from you. And that's excellent. And I also see speakers and panelists from various disciplines, radiologists, radiographers, physicists, and we talk about collaboration, and that is the way to go. Congratulations again to Dr. Rijo, who put this up. Not easy, I say, coordinating so many people at this time. So thank you once again to all of you.
Thank you, Emeritus Professor Dr. Kwan Hung and the chair of AsiaSafe, who was, along with Dr. Evelyn Ho, the President Chamari, and the chair of AsiaSafe, Professor Ang, has been very, very supportive in the MR safety campaign in our Asia-Oceanian region. Thank you once again. We have got a few questions that have come up in the chat box. One question is, any of the speakers or panelists can take it. My question is, can we make all these devices MR compatible? This is a question from Dr. Vishwanath. Amel, do you want to answer?
No,
Sheeba,
no,
you want to answer? Can we make all these devices compatible? I think we are slowly moving towards that phase.
Yes, but still, there are a lot of things left behind. But to make everything compatible is not possible. But most of the equipments are now becoming MR conditional. So that's what we should be aiming at, and I think that is possible.
Okay. They're asking for like metal stitches by staple knees, staplers, knees, hip, femoral, neck. Field strength is which field strength is better, 3 Tesla or 1.5 Tesla for compatible conditional? I didn't get that question properly, but that is what they've asked.
I think they're asking whether the field test has a relationship with the MR compatibility, which it does. So 3 Tesla is always a more powerful magnet. So, but then compatibility, as Dr. Amel had said, most of the devices now because which are already made. Also, they are making MR compatible now. But few things, there are still challenges, and these metallic staplers, as you said, immediately post-op it is an issue, both with artifacts also, even and with compatibility also. But then after that, I think they are okay. But still, we get a few artifacts with these staplers, even when, especially if they have put it in the abdomen. Say, suppose a cholecystectomy done with an MR stapler, then we screen the liver. We do get some artifacts on it.
Right. I can't see more questions in the chat box. So, if any of the panelists or speakers want to ask any questions, we are welcome to discuss. We got 3 more minutes to go before we wind it up. Let me congratulate all the speakers and the panelists for the wonderful sessions, wonderful sharing of knowledge that you had, wonderful thoughts, and thank you for accepting the invitation to join this platform. In a short notice, we were able to bring together radiologists and technologists from all over the country, and I'm extremely thankful to each one of you. If there are no more questions, let me request the Vidocto technical team to show the QR code for your. These are the feedback QR code. Please do scan it and answer your questions, and that will make you eligible for a certificate of participation for this webinar. Please do give us the feedback form. Feedback form is basically on the comprehension, on the quality of the lectures you had, and also share your ideas on what are the topics that you need and how can we improve these webinars. So these are basically the feedback forms. If you scanned it, please do fill it and send it back to us. Your certificates will be sent by the technical team soon. Now, let me conclude this webinar, which we started at 6:30. It's almost 1.5 hours. I'm really afraid of Professor Ang had always insisted that every session has to end within an hour, but we have exceeded a little bit. But I think the quality of the sessions worth that kind of an extension for another 20 or 30 minutes. And I am extremely thankful to the president of AOSR, Dr. Chamari Chuapechapon, for joining us and gracing this occasion, and also to the chair of AsiaSafe, Emeritus Professor Dr. Kwan Hung Ang, for joining us and giving the message, and also to Dr. Evelyn Ho, the past president of AOSR, who has coordinated a lot of efforts and joined us, and then is listening to these lectures here. And also to Dr. Sandeep Kautale, the president of Indian Radiological and Imaging Association, who has seriously taken these MR safety initiatives and even has discussed with me on MR safety accreditation programs throughout the countries. I'm really hopeful his presidential tenure will see a lot of MR safety initiatives in India this year. Let me also thank the speakers and the president-elect of IRIA and the executive councillor of in charge of education committee, Dr. Murali Krishna L, for that wonderful lecture and the commitment that he has already made for the MR safety initiatives, a roadmap for India. The next two lectures, by implant screening by the technologist, MRSO, Ms. Sheeba Kumari, and Dr. Amel Antony as a radiologist perspective was very wonderful lectures, giving us a lot of insights and a lot of knowledge. I'm extremely thankful to both of you for that wonderful lecture. To the panelists on the Zero Action Plan for Zero Tolerance to prevent 3 major accidents, Dr. Pradosh Kumar Sarangi, Dr. Pankaj Sharma, the Secretary General of Indian Radiological and Imaging Association, Dr. Reshmi CP, and Dr. Suvinay Saxena, the AsiaSafe Licensing Committee member for India. All of them have contributed to this with very, very insightful thoughts and also very proactive action plans, I'm sure, which soon take shape in our region. Let me also thank Vidokto, the technical partner, and all the audience who have logged in today for this wonderful lecture. Thank you very much, and good night. And for all those in this part of the world, good night, and all those in the other part of the world, good morning. Thank you all.
Thank you.
Thank you.
Thank you.
Thank you.